weeks. So that's what's called a non-opioid detox. The next thing we can do is what's called a rapid naltrexone induction. And we haven't done this too much down in detox because it takes a real motivated patient. Again, we want to get the patient to the extended release naltrexone, the Vivitrol shot, the blocking shot. And it would be ideal if we could bring somebody in that's using heroin or opiates, detox them and give them a shot before they even leave detox. Then they can't use for a month. That would be great, and the craving would be down. But it's hard to do. This is how you can do it, though. It's called rapid naltrexone induction. Studies have shown that if you get the naltrexone shot, if you get the Vivitrol, that's got twice the retention rate of oral naltrexone. So how do you do it? You give them a little buprenorphine, a little Suboxone on day 2, just a little bit, 4 milligrams twice a day. And then you begin the naltrexone in very low doses, 3 milligrams on day 4, 6 milligrams on day 5, 25 milligrams on day 6, 50 milligrams on day 7, and then you can give the shot, the Vivitrol, on day 7. And you can also give them clonidine and other medications while they're going through this. And then they would leave detox having gotten the shot. But again, it takes a motivated patient because they're going to get sick as they get these low doses of naltrexone. Another method is, if the addiction's not too severe, is to use even less buprenorphine, just like 4 milligrams on day 2, and then increase the naltrexone more rapidly. So the problem with this is that it does result in withdrawal. It takes a very motivated patient. They may have flu-like symptoms for a few weeks. And sometimes what you can do is give them a naloxone challenge, a Narcan challenge. Instead of giving them the oral naltrexone, you actually give them a shot of Narcan when they're going through this. And if they don't have any withdrawal from the Narcan, then you can go ahead and begin the oral naltrexone. The next one is takes even a more brave patient, which is called rapid opioid detox. And this is just taking somebody in that's been using heroin and giving them the blocker, giving them the naltrexone, putting them into withdrawal. I've tried this on a couple patients. Some patients just came in and they said, you got to give me a blocking drug. If I have any chance to use, I'll use. I don't care how sick I get. The problem with this is they just get too sick. I've done this on a few patients, and they just get too sick. Sometimes they've ended up over in the hospital. One patient ended up in the intensive care unit because he got so sick. And then the last one is called ultra-rapid detox, and this should never be done. This is nothing we would do here at Fairview. But you might hear advertisements, or you might hear stories about people getting this. Here you take somebody that's a heroin addict or an opiate addict, and you put them under general anesthesia, like you're doing an operation. And you put a tube down their nose, and you give them naltrexone through the tube. You give them Narcan through the intravenously. So you're putting them into full-blown withdrawal while they're under general anesthesia. This isn't recommended is because when they wake up for the next week or so, they're sick, they're in withdrawal. It doesn't really help. They're very sick, and it's been shown that some people, it's so dangerous they can actually end up with catastrophes having done this. So the American Society of Addiction Medicine has come out saying that this should never be done. So I just mentioned it in case you hear about it. Ultra-rapid detox is not a good idea. Let me say something about medication-assisted treatment. The definition of this is using medications in combination with counseling, combination with the treatment that you're getting in Lodging Plus, and behavioral therapies. The rationale is for medication-assisted treatment is that you have a chance to stabilize the brain chemistry. It blocks the euphoric effect of the drugs. You can be on medication so that the opiate addict can't get high. You can have medication to relieve the cravings. And the National Institute of Health has said that the safety and efficacy of medication-assisted treatment has been unequivocally established. The alternative to medication-assisted treatment is abstinence. The problem with abstinence, it's ideal and it'd be great if you can just kick the drug and go on and live happily ever after and not use. But it's got a very high relapse rate for opiates. The relapse rate is 90 to 95% if you're not on medication. And there was a study called the POET study. It was the Prescription Opioid Addiction Treatment Study. And this was a National Institute of Drug Abuse study from Harvard, and was the largest study for prescription opiates ever done. And the conclusion was that tapering buprenorphine off led to nearly universal relapse. When you take people and you take them off the buprenorphine and there's nothing going on after that, there was almost universal relapse. So that leads us back to medication-assisted treatment. And for opiates, there's 3 drugs: methadone, buprenorphine, and naltrexone, which is the Vivitrol shot. Let me say something about methadone. It's been around for a long time, since the 1950s, probably 1940s. It was actually invented in World War II. It was called Dolphine in Europe, named after Adolf Hitler. And they thought they had an opiate that would last all day. But there's years of experience, and there's many, many studies showing that it's effective in reducing opioid use and reducing crime. It's one of the most overproven treatments in the entire drug abuse literature. The problems with methadone are that it requires frequent daily visits to a methadone clinic. There's the mingling with other addicts at the clinic can create a problem, and it has some physical side effects, like it does something to the heart, something called a prolonged QT level. That can be a problem. So those are the problems with methadone. Buprenorphine, I spoke of this earlier with regard to its use as a detox medication. It works well in detox, but it was really invented for use as a medication-assisted treatment. It's basically was invented with the idea that people would stay on it for opioid maintenance and increase their chance of recovery. It became legal when Congress passed the Drug Addiction Treatment Act in the year 2000. It became available as a sublingual medication in 2003, so 12 years ago. Doctors have to take a course to get a special license to prescribe it. If they take the course, they can prescribe it to people for opiate dependence. They can only prescribe it for 30 patients the first year and 100 patients after that. So it's limited as to how many patients each doctor can have. And the problem is that not many doctors are signing up to get the license. The results are good. Most studies show 50 to 60 or more % abstinent compared to less than 10% with no medication. Patients feel normal usually. If you take a person off the street that's not using drugs and you give them Suboxone, they're going to feel it. But if you take an addict and you get them stabilized on it, they just go day to day. They really don't feel any different than the normal population. And then they can live a sober life. There are some problems with buprenorphine. So these are the benefits. Treats addiction like other diseases in a doctor's office. You can sit in a doctor's office with the high blood pressure patients and the diabetics and just get your medication. It's effective and the patients feel normal. The problems are, they're not real problems, just something that the doctors need to remember. Buprenorphine is strong. 1 milligram of buprenorphine equals 30 milligrams of morphine. So usually 4 to 8 milligrams of Suboxone or buprenorphine is plenty for somebody on medication-assisted treatment. Another problem is getting people off is not easy. People always talk about methadone. It's so hard to get off methadone. Well, it's hard to get off Suboxone too, but it can be done. It just needs to be done in the right way, very slowly, with a good doctor and a good patient. You just gradually go down, and I've taken lots and lots of patients off of the buprenorphine, and it goes okay. It's best used in combination with people going to meetings, with having a spiritual recovery program, with having a sponsor. If it's used all by itself without anything else, it's less effective. Patients should be involved in recovery support. They should avoid using other addicting chemicals. Occasionally, patients become addicted to Suboxone, addicted to buprenorphine. I've had some of my Suboxone patients that their addict takes over and they start to abuse it like they were abusing OxyContin or whatever. They start losing it and taking double the amount and things like that. That usually responds when I become aware of it, which is usually pretty quick, by just increasing the number of visits. Instead of having them come once a month, I'll have them come once a week. I only give them a week at a time. If need be, I'll have them come twice a week. So usually responds to tighter controls. The benefits of Suboxone are they have time to establish a normal life. They have time to let the drug memories, the memory of what it was like to feel what heroin did to you, let that fade with time. Let new memories develop, and that's what needs to happen for a person to not have craving anymore. And the requirement of regular ongoing visits. I see my patients once a month. Usually that's invaluable. Usually that's very helpful. It keeps them on track. And there's a relief of compulsion, obsession, preoccupation with the buprenorphine. Time to establish a normal life, time to let the drug memories fade, regular ongoing visits, and relief of compulsion, obsession, and preoccupation. The last medication that's used for medication-assisted treatment is naltrexone. It's got two forms. It comes in pills, 50 milligram pills, or a shot called Vivitrol, which lasts for a month. The oral med, the Vivitrol pills, the naltrexone pills have been around for a long time, but they aren't very helpful because the opiate addicts will just stop taking them and then they go out and use heroin again. So the results aren't that good. It's much better with the shot. The shot lasts for a month. Once you get the shot, the addict is going to be sober for a month. They can't use. They literally can't use. They can't get high. A 50 to 60% retention rate at 6 months with the long-acting Vivitrol. Naltrexone is what's called an almost perfect blocker of the opiate receptor. It goes there and you are blocked. You can't get high. It's well tolerated. There's no abuse potential. You just don't get high from it, so people don't. There's no diversion because it's a shot, and there's no withdrawal when you stop taking it. The thing with naltrexone is that having withdrawal when you stop Suboxone actually makes sure the person comes back for the next visit. If they miss an appointment and they're out, they're starting to get sick, they're going to get back in. If somebody misses a shot, they're not going to get sick. All that's going to happen is the craving's going to go up. So they may miss the shot. So you have to have a motivated patient that really wants to be sober and keeps coming back once a month for the shot. So who are good candidates for naltrexone, the shot? Somebody with a high degree of motivation for abstinence, active in 12-step programs, somebody that Suboxone hasn't worked for, somebody with a less severe addiction, somebody for who relapse would be disastrous, a physician who will lose their license if they relapse, a pilot who won't be able to fly, parolees who are going to be thrown back in jail. Those are pretty good candidates for the shot. Poor candidates for the shot would be anybody that's overdosed, has a history of overdoses. The worry with the Vivitrol shot is that if you miss getting the next shot and it's a couple days later and you're getting a craving and you go out and use heroin, your tolerance is so low that you could overdose and kill yourself. People that don't feel good, they don't feel normal when they're off of opiates, that's not a good candidate. People with chronic pain, if they're on this shot, there's really nothing you can do for the pain. People with advanced liver disease, women that are very, very skin, they don't have much muscle because it is a big shot, and people with low platelets or high INR. INR measures your blood clotting ability, and if you have a liver disease that makes you not clot your blood, that wouldn't be good. So that's it for opiate addiction. I'm going to go on to benzodiazepine addiction, and then at the end you can ask questions. So benzodiazepines, like I said at the beginning, are common ones would be Xanax, Librium, Klonopin, Valium, Ativan, Restoril, that's a sleeping benzo. We don't see that much anymore, and we don't see much Halcyon anymore, but those are the common benzos. What do? They bind to a receptor in the brain called the GABA receptor. They potentiate the effect of GABA, and they result in the central nervous system being inhibited. They cause relaxation. They cause relief of anxiety. They sometimes will have a decreased memory. They help you sleep. They work as muscle relaxants, and they will stop seizures. Those are the things that these benzos do. Side effects of the benzos: drowsiness, fatigue, depression, blurred vision. Somebody's getting too much, so vision will get all blurred, and a decreased appetite. The tolerance and dependence: you can get addicted to a benzo after 2 weeks. When people use chronically, over and over for years, they can get dementia, decreased pain control, decreased ability to concentrate, decreased problem solving, decreased memory. So nobody, very rare, should anybody be on a benzo long term. So people get addicted to benzos and they start to abuse them. They're the most frequently abused medication, second only to the opiates. The opiates are more, but the benzos are number 2. The most commonly abused benzo is Xanax, followed by Klonopin. And they're rarely the primary drug of choice. Usually you don't see people that are only abusing benzos. You'll see people that are using benzos in heroin, or benzos in meth, or benzos in cocaine. Cocaine and meth addicts will use it to calm down. Heroin addicts use it to treat withdrawal symptoms. Methadone patients take it to boost the effect of methadone. So it's usually combined with other drugs. And it's interesting that people without addiction, non-addicts, if you give them a Valium or a Klonopin or Xanax, they don't like it. And they've done studies that actually offer non-addicts benzos and placebos, and they prefer the placebos. They don't like the way the benzo makes them feel. So benzo withdrawal, it's extremely variable. We have people coming into detox, and young people, they'll say they're using 20 milligrams of Xanax a day. And they have very little withdrawal. It's interesting. Mostly subjective symptoms, very few observable changes, and they don't really get blood pressure and pulse changes like you see with alcohol. What predicts somebody that's going to have a bad benzo withdrawal? Well, the duration of use, how long they've been using, whether they're using alcohol in addition to the benzo, if they're using other sedatives,